Hi. So today we'll be discussing the optics of myopia and its correction. So it can be applied to pathologic myopia. So it's similar outline, but of course, pathologic myopia we have the core components of the pathologic myopia. So yeah, so this is the outline. Um, Introduction or definition, the classifications, the optics, then the corrections. Under the correction, talk about the effectivity and some calculations too that can be asked in the exam. There's some exam they may not require calculator, but the after when I did that you understand, I mean you could guess the answer based on the understanding of the optics of the myopia. So myopia is actually a passive condition in which parallel of light do not form a point focus. Rather, they form a point focus, I mean, but the point focus they form was in part of the retina. So the parallel is a passive condition with parallel of light form a point focus in front of the retina. So this is what it means. We still draw the diagram when we get to optics. So the idea is just that let's just explain what the metropia is expected. A normal person that doesn't have a passive error will expect parallel of light that are coming from infinity, okay, conveniently 6 meters away. You know, infinity not to Z is 6 meters away. So expect those parallel of light coming from infinity from a point focus on the retina. Like I see it's from on the retina. This is what we expect for metropia. And so let's label the part. This is the principal plane representing the cornea and the lens. So the practice surface of the eye, essentially. Then this is the retina. And so you can see these rays are parallel coming from infinity. That means 6 meters and above. And they form the point focus on the retina. So the second focal point is on the retina. So this is the emmetropia. That means patient does not have refractive error. So that's emmetropia. The normal refractive error. So when I have this second focal point in front, it's what's called myopia. So that's why we define it as a refractive condition in which parallel of light from a point focus in front of the retina. So that is the definition. So um yeah, the we have to talk about classification. So these are just stuff that you talk about. We can be simple or pathologic. Simple is the school one. Uh that can be corrected up to 60. That's a specific thing about the simple one. You can correct it up to 6. Pierre can ask you 4 and then correct it up to 6 or 6 correct it up to 6. You know that is actually a simple school myopia. We can have pathologic myopia. That was not correctable as to 6. And there are pathological features that are attached to it. They also classify it based on etiology. It can be axial if the axial length of the cornea is much, and which usually account for majority of the cases, like cases of congenital glaucoma, where we have ophthalmos, the IOP is so high that it keeps stretching the eye, and so the axial length will be high. And so in congenital glaucoma can have axial myopia. And of course, can have a mixture of the curvature myopia too, because the cornea will also become flat and flatten out, so we can balance each other out. But that is the meaning of the axial myopia that we're talking about. The axial length is much, if it's long, to cause axial myopia. And that's why when you're doing biometry too, when you compress too much on the cornea, it can shorten the axial length, and that can give you a wrong result because of the shortening of the axial length. So that would be in the myopia anyway, but like it's telling you that you have to be very careful to when you're doing biometry, so that's not to compress the eye. Also, you can also have curvature myopia, that is the curvature of the eye increase, which could be in form of the cornea, you know, or the lens. Cornea like catconus, lenticonus. The cornea like catconus, while the lens like lenticonus. So that's the or lentiglobus. So that's as the case may be. So when you have the increase in curvature, it can also cause that index, when there's gain in refractive index, like in diabetic myopia, you know, in which there is swelling of the lens and then there's myopic shift. So that can also cause index myopia. Then you have positional myopia, which you understand it better when you get to the effectivity. So when the lens is displaced anteriorly, okay, because the lens the lens is a positive lens. When in the space and theory, there's going to be more effectivity. It's going to be more effective. So the lens that was inside the eye, maybe like in the back, I mean in the face where it's supposed to be, the eye loss space and not. So where it's supposed to be is 15. By the time you know the space, maybe from trauma or from hereditary disease like Marfan syndrome or Metastatic syndrome, these ones are not good. Then the space into the anterior chamber, which will cause a myopic shift, and that's why they can have myopia in all those Marfan syndrome and all. So, also the classify based on the degree of the severity. These are the things you memorize before you get to the optics. The low, moderate, and high. The low is less than or equal to -3. The moderate is -3 to 5 to -6. And the high is -6. Usually pathologic myopia is -6 and above with pathological features. So of course you talk about the clinical features they can have, which is can read those ones up, and then the measure finding. So let's move to the optics. So the optics again can start by explaining what metropia should be, which we said when the parallel rays of light focus on the retina, the second focal point is on the retina. That's for the metropia. So what's now happening in myopia? All right, so this is what happened in myopia. Can I even use it to compare the diagram? See. So that the mood is metropia, then for myopia, we can based on axial length, or of course can be curvature, so represent it like this. So you can see the axial length just to show, not necessarily label. You can just see that axial length is longer. So the axial length, so this axial length from the principal plane to the retina is longer in myopia, so you can draw the two together if you want. Um, so let's define optically what myopia is. So the principal axis, this is the principal plane on retina. So semi-myopia is a refractive condition in which parallels of light do not form a point focus on the retina. So parallels of light are coming from infinity like this. So they form a point focus in front of the retina. So the point focus, the second focal point, they come like this. So by that they convert because the eye has too much power, which we have listed because it's going to be converging in front of the retina. So it will block. They won't see it because it's being a vitreous. Okay, so this is where the second focal point will now be their own F2. As is the fonts of the retina. And so that is um the diagram. So after knowing that, so the next thing to talk about is the far points. You have to talk about far points because that will help you understand the correction into in in uh in myopia. So let's talk about the far point. The far point of distinct vision is the farthest point in which an object must be placed to obtain a clear image on the retina when the accommodation is relaxed. It has a peculiar definition, is the farthest point in which an object must be placed to obtain a clear image on the retina in a relaxed, non-accommodated eye. So for the myopia, okay, so we explain that what that means one by one. Okay, because you need that far point to understand the correction. So this is the principal plane. And then plus this is the retina. Right, so we can say far point is the farthest point in which an object must be placed to obtain a clear image on the retina. Okay, so by the way, far point for metropia, this eye that doesn't have refractive error is at infinity. That means for vision that doesn't have refractive error, the farthest point an object can be where they will see clearly 6 meters and above. That means they can see 6 meters and above clearly without accommodation. That's the meaning. So in infinity, that means 6 meters and above. Vision that doesn't have refractive error should be able to see object as far as 6 meters clearly without accommodation. Now, for the myope, so it's that farthest point. So for the myope, the farthest point is actually located at a finite distance in front of the eye. That is measurable for the myope. The far point is measurable. So it's actually located at the finite distance in front of the eye. That means located at a finite distance. in front of the eye. So it's measurable. Okay. I will tell you what I mean by measurable. So it's actually where the object must be placed. So that means this is where the object must be, provision that is myopic. That far point is where the object must be. So that the rays that are coming from that object, once they hit the eye, okay, and it's going to be converged by there and then it will form it on the retina. And now see from this diagram can define what the far point is. That means it's the point of distinct vision. It means that the farthest point, which is this place, as measurable, that an object must be placed to obtain a clear image. You can see the image formed on the retina now. Unlike the rays that are coming from infinity initially, you can see this rays form on the retina. The rays form on the retina. So once the object is here, they will see it. And that's why we call it near vision. You can see it's measurable. That's why they call it nearsighted, because you can actually see the near. You can see this is near. It's not like it's coming from far, infinity. Compared to this diagram, this is come from this things that are coming from infinity far away. Can see that come far away. They will form individual, so they won't see that one. Since they are near, because that's where the far points will be, they will now see it. So do you now understand why they call it nearsightedness? So that's the reason why they call this, because it's just the near one that they see. And it's because the far points will be the near one. So now, and then we leave it that one's minus R. Now, what is the implication of this that I was trying to explain? The meaning is that if you have a child, okay, if a child comes to cleaning, and then you could see that they are bringing the maybe the tab that the child is using to play video or something almost close to the eye. You can measure that distance. That distance can just calculate the power and estimate the amount of refractive coefficient you have. So that means the farthest point. That's the meaning. That means if you move close to the eye like this, that short distance from the eye to the where the tap is, where the patient is able to see clearly. But sometimes it's almost touching the eye. You can guess, oh, this is like maybe 8 centimeter. I can estimate the refractive error. That would not be um power. That will be power equal to 1 over f. That will be 1 over 8 centimeter. The 8 will be converted to meter. That will be 1 over 0.08. Or you can do 100 divided by 8 straightforward. I can watch few of the videos on how to calculate faster. So that like 12.5 myopia. And I'm like that, oh, this patient is actually moving the tap close to the eye is like a 12.5 decade. So that's the clinical application. So give you an idea, if a parent is saying that my child also moving close to TV, can estimate that distance and have an idea of the far point. So that means that's the place where the object must be so that they can see. And that's why sometimes for a patient that's like maybe has like 10 diopter, minus 10 diopter of myopia, that means the far point would be again power equals to 1 over f that we always say. So the focal points that f will now be so that will be 10 equals to minus 10 equals to 1 over f because it's minus. So if you get that, the focal length will now be 1 over 10, and that will be 0.1 meter, and that will be 10 centimeter. That means anything more than 10 centimeter, patient will not see. Because 5 want to be at 10 centimeter, that's the farthest they can see. You get, and that's why they can have issue with recognizing people's faces. The replied, the doctor, people used to tell that I don't get them. It's because I'm not seeing them. So with that question, farthest they can go is 10 centimeter. And so that's why it will be like that. So um the next thing will be the treatment, which we'll talk in the next video. Let us see. So of course I talk about clinical features, everything, and also the next thing will now be the correction of the um myopia, which we will show in the next video. Thank you.